Hi, and welcome to Telemental Health Supervision Basics. I'm Dr. Donna Sheperis, an approved clinical supervisor and a board-certified telemental health provider, also a licensed professional clinical counselor. And I am here to talk a bit about some of the similarities and differences as we embark on supervision in the age of telemental health. Not only are we providing telehealth services as clinicians, but we are now providing supervision services to our supervisees, to our associates, and some of us to our trainees who are providing telemental health services. A bit about me: I have been a licensed provider at some level or in some state for over 30 years now. I began working fully in a distance clinical service position in 2016 and started fully online practice at that point, and have maintained that ever since. I'm also a professor and educator at Palo Alto University, where I serve as department chair and director of our e-clinic. Our e-clinic at Palo Alto University is a fully online telemental health clinic, and our student clinicians see clients from all over the state of California, where they are also using not just digital Zoom-based therapy, but therapeutics, digital therapeutics, chatbots, apps, and other innovative and technology-based interventions to support the work that they're doing with their clients. Now, as a supervisor, and I've been an approved clinical supervisor or a board qualified supervisor since the early 2000s, which is about the time that states started really qualifying specifics around supervision for pre-licensed professionals. Most of my training was in standard models of supervision, as for many of you, it probably was as well. And what we're seeing today is that our boards and our accreditation standards are asking us to look beyond standard models of training. If we're going to supervise our trainees and our associates who are doing work using telemental health, then we need to know a little bit how to supervise also using those types of practices. So whether you are using telesupervision to supervise students who are doing in-person and remote clinical work, or just remote clinical work, any combination, you might be doing some in-person supervision, some telesupervision. This presentation should give you a little bit of a refresher on the fundamentals and how to adapt it and some of the nuances of bringing your supervision self into the digital world. If you've been doing supervision for a while, you probably already made that jump and have learned a lot along the way. And I wish this was an in-person training so that we could have this conversation live, because I'm sure that all of you have a lot of stories to bring to all of us that are part of this. But until then, this is maybe a bridge to begin to start that conversation. I'll take a moment to share my screen and walk through some of the aspects of the practice that is now being called telemental health supervision. Okay. Wanted you to have access to how to reach me, my contact information, my email at paloaltou.edu in case you have any questions or comments following this training. So let's start with a general idea of who we are from a competency standpoint. Who are we as clinical supervisors providing telesupervision to our associates and our trainees? Let's take a moment to do a skills assessment. So I'm going to ask you for the next 4 slides to reflect on the items that are presented and consider where do you fall on this Likert scale between poor and excellent. Communication skills, you have 3 areas to think about. So let me pause here. You're reflecting on your ability to establish that rapport from a distance, which you've probably learned to do with clients, how to give those instructions and be clear over an online platform, and how to use those active listening skills that we know translate not just with our clients, but with our supervisees. So the next series of questions that we want to assess ourselves on relate to our proficiency and our comfort and affinity for technology. Many of you are providing distance services yourself, so you have some competence and familiarity with those platforms. You may not, or you may have just started using them for supervision. So how good are you at troubleshooting when the technology fails you? Because it will. It's not a matter of if, it's always a matter of when with technology. How good are you at using alternative tools, getting out that whiteboard aspect of the technology, using screen sharing, other ways to reach your clinician? And do you have any other AI tools that you bring in to your supervision work? The next series of questions where you're assessing your own level, where you are now, has to do with your understanding of the ethics related to supervision from a telehealth lens. Now, this series of questions, I find that most distant supervisors feel pretty confident in. We tend to get routine training on ethics every year, and more recently, we've seen ethical codes and ethical decisions and cases related to the provision of telemental health, as well as maybe the supervision of telemental health presented in those workshops, which has caused us to become a little more aware of how to complete our informed consent, our supervision contracts. That's generally on the forefront of our mind. I don't know that we've put as much thought into how technology may alter the setting of boundaries with our associates, but it is something to consider as we move into this type of supervision. I find that supervisors are already pretty well aware of the need for boundary setting with their associates. And then the last series of questions for this self-assessment have to do with our own clinical competence to be supervisors. You know, the reality is that you're a supervisor for a reason, and you've been chosen by your supervisees for a reason. Your supervisees want what you have, and your agency likes how you operate. If you're in an agency, they want you to be the one that shares that wisdom with interns or new employees. If you're in a smaller practice, you want to be able to bring those associates in and mentor them and help them grow. And they want to be part of that with you. So you know you're pretty good at what you do, right? I hope you do. You're an established clinician and you know how to help people grow and become better in their lives as your clients, and you've been able to translate into your supervision. And now, having learned how to do that as a distance telehealth provider, you're learning how to do that with your associates in supervision using the same types of technologies. So, you know, your self-assessment there may be growing and feeling pretty competent. Using evidence-based practice. You're probably highly skilled in applying your theories of clinical practice and supervision practice in supervision. But applying them in telesupervision, you may not feel as competent. And that's okay because we don't have a lot of evidence-based practice around telesupervision yet. It's really too new. You're really on the cutting edge of this becoming well-researched. So we're taking a lot of in the room practice and theory and bringing it to a remote setting. Likewise, testing your flexibility and your ability to be adaptable and go with the flow when you're taking what you're used to doing with your supervisees in person and providing it in a Zoom, either individual or group setting. And I'm using Zoom as a catch-all for video because the platform doesn't really matter. It's about being in some type of interactive video setting. So you've done a self-assessment, you have a sense of what your strengths are, you have a sense of things yet to learn. There are so many things for all of us yet to learn. There are very few experts yet because, as I mentioned, there's very little research available to us. We are learning as we go. So let's start with the refresher. Let's just start with the basics. And with the basics, I'd like for you again to reflect, but instead of thinking about your competency, I'd like you to think back to when you first entered the profession. For some of you, it wasn't that long ago. Maybe for you, it was just 5 years ago, and you're coming into supervision now and you're ready to start supervising. For someone like me, it was a long time ago. And when I had my first supervisor, in my master's program, you know, that was a supervisor who was outside my discipline, who had no training in supervision, and met with me on a regular basis, but really didn't have any goals. We didn't have a supervision contract. There was nothing very formal about it. He basically talked to me and took me around to see various patients in the hospital and gave me opportunities to meet with different patients and learn a bit about some more severe mental illness, which was not something I expected as someone who is in a master's license eligible program. And so some of my supervision was really effective and really good, and I grew and I became confident in areas of myself that I didn't know were possible. Like just saw, I grew from a theoretical perspective. I moved away from the theory that I thought was going to be right for me in my graduate program into a more complex theoretical approach. And my dog would like to join this recording. And I don't have any way for her not to, so I guess she'll be around a little bit. But some of the supervision I got was not good. And that taught me a lot too. Some of the supervision I got was dismissive. It was a person who didn't listen when I wanted to talk about something that I thought was happening with a particular client or that I was concerned about. I worked with supervisors who wanted to tell me what to do or only wanted to talk about cases and didn't really want to talk about what I was learning about myself as a therapist. And then what kind of supervisor are you now? Wow, years later, with having become a board qualified supervisor in my home state years ago, now an approved clinical supervisor with a national organization, supervising for decades. Oh, makes me feel old. Yeah, very different kind of supervisor, very planful, thoughtful, and intentional supervisor. What do you bring to your supervision practice with the people that you're working with your associates? What's your goal? What do you know about the supervisory relationship? What do you want out of it? Where do you see yourself in that relationship? And what do you want from those associates? Depending on where you are you purely a clinical supervisor? Isn't that the best? Isn't that the best when your entire role is clinical supervision? But let's face it, most of us have to do some administrative supervision as well. So most of us do a little bit of both, right? And depending on your level of experience and training, how well prepared do you feel? Now, those are things we think about as we're considering what's our competency and where are our needs as a supervisor. As you were going through your own training, you probably took some supervision, continuing education, or maybe you even had a class in it. I know in a PhD program, we had a full class in it. Typically in a master's program, you don't. And most of us had some continuing education hours in clinical supervision. So most of us are working with this type of a working classic definition of clinical supervision, that we really are providing an intervention to our associates. We take our knowledge and skills as the senior member. Doesn't always mean the oldest, but just the more senior member. We've been in the profession longer. And frankly, for the longest time, that's really all it took. Oh, you have a license and you've been practicing, you get to be the supervisor now. Before we established really supervisor criteria and qualifications and needs, it was just who's been doing it a while, you get to be the supervisor. And then states and other boards and regulatory authorities said, you know what, we need supervisors to be trained. And now we need them to be trained in distance supervision, telemental health supervision. So when we are providing that intervention to our more junior member, we're in a relationship that isn't just a mentorship. It's also evaluative. It does have a goal of the person knowing how they're doing. It has a time span. They're going to be with you for X number of months, years, or clinical hours. And our responsibility is to help that person grow as a professional. That's the first responsibility. And I like to remember that because it can be very easy for me to focus in on case review, but the primary goal is to enhance that person, that supervisee. Of course, I want to monitor the quality of the services they're providing to their clients. That's a huge goal. But I'm also serving as a gatekeeper, because if I am working with someone who is not right for the profession or could even be dangerous, that's someone I don't need to endorse. And I have promised the regulatory authority or the state that I won't endorse them if that is, if that's what I discover along the way. I do this. I have to record this. You have to lay down. I don't know what to do with you. We'll forever get this done. We're gonna be good for it. Lay down. Get in your bed. Get in your bed. Get in your bed. Get in bed. Lay down all the way. All the way. All the way down. When we think about how we approach our associates, we really come at the work that we do from one of three roles. If we're going to follow the Bernard discrimination model, which many of us do, we come to the work of supervision from the role of the teacher, the role of the counselor, or the role of the consultant. And what we're trying to do in the focus of our supervision is that we're either thinking about an intervention, we're thinking about case conceptualization or an overall big picture, or we're looking at something that might be a bit more personal, how it relates to the dynamic between the associate and their client. The role of the supervisor is interesting and fun to navigate because it allows me to wear the very many hats that meet the needs of my clinician at any point in time. I can educate when needed. I can provide case consultation when needed, but I can also help that clinician grow by understanding themselves better. So Bernard looked at using that teacher role as a way to understand, what does this supervisee need to learn? And let me help them. So if I have a supervisee who has never worked with parents of children with autism, then I'm going to want to help educate that supervisee on what that is like, what resources they should check into, how to best prepare for that work. And this is an area where I can also check their knowledge. Did you do the reading I asked you to do? It's also a place where I, in that teacher role, do my evaluation, my formative weekly, when I meet with you, you know where you stand with me evaluation, and my end of the period, end of the time that we're talking about for hours, where they get their written feedback on how they're doing. And that's pretty easy to do electronically because I can send PDFs. We can watch a resource together. We can search for resources together using an electronic platform. The consultant role, I'm generally more of their colleague, and I am sharing my thoughts on a particular case, or we're brainstorming interventions. We're thinking about what's best practice, what's the right way to address a goal or frame a goal. And that's also fairly easy to do via distance. The counselor role that I take is more on honing in on those interpersonal and intrapersonal reactions and interactions. And that could be between the supervisee and their client, or it could be between the supervisee and me. That's where it gets a little bit trickier, and also a little bit, as you know, in supervision, a little bit more fun, because I get to call upon my skills as a therapist to say, there's something going on here, and let's figure out what that is. That can feel a bit more difficult if you aren't comfortable doing telemental health yourself. So if you've not developed a comfort with doing video sessions, then having those conversations over a video platform may not feel as comfortable to you. So you would want to watch to see if that restricts your ability to have those very important conversations that might be keeping one of your clinicians stuck or preventing them from taking an action or moving forward with a client. In addition to using Bernard's model for the roles that you take as a supervisor, most of us also use a developmental model when we think about our associates and when we think about our supervisees. The supervisee developmental model that was initially developed by Stoltenberg is a process model. And it looks at the student experience, the associate experience, the pre-licensed clinician experience as a series of stages. And the trainee progresses through those stages. Now, when you're supervising postmasters, pre-licensure, you don't see it as harsh and as long in the early stages, I hope. Sometimes you will. Sometimes you will get a very nervous graduate. But if you supervise some student interns, you'll see it probably even more so. What the model does is give us this nice conceptual way of thinking about how these students and how these trainees progress. In the early stage, in that first stage of dependency, oh my goodness, they are just attached to you. They are scared, but they're also excited. They want to be there. They're highly motivated, but they are kind of petrified and they don't know what to do. And they ask you for direction on everything. In the second level, they start being a little bit less frightened, a little bit more autonomous, but they're a little bit more overwhelmed as they realize all of what they need to do to be a practitioner in the real world. Now, in that third level, where they're still dependent, they develop some confidence, but they're still seeking you and they're still touching in, they still need you. And then in that last stage where they're autonomous and fully, they don't need you at all, you probably won't see that until they are actually after licensure, right? This is where we hope to be 10 years down the road, not during our associate time. So, and every time we start over a new job, we have a little bit of this happen every time. In the other processes of this development phase, the way we can use this lens and remember that dependent, autonomous, conditional, and all good, competent model or competent phase. We need to pay attention to how they think about themselves versus their client, how motivated they are, and how much autonomy they feel. So in those early stages, those trainees and associates that you have in those first month or so, they are so self-focused. All they can think about is, am I doing this right? Did I fill out this form right? Did I go to the right room? Did I click the right button? They're very self-focused, and that actually gets in the way of their ability to work with their clients. And you notice it and you try to reassure them so that some of that anxiety will settle and they're able to then be present. They're very, very motivated though, and they're not autonomous at all. As they go through those stages, they become more aware of their client. Motivation it'll lag a little bit. Sometimes that's related to the abundance of paperwork that we have in our discipline. But they become more and more autonomous, which is what you want. You want them to be able to make good choices, to be motivated, and to be focused on the work and on their clients. They're going to be anxious about performance then. They're going to be anxious about your evaluation of them. And that's okay. They're going to check in with you. They're going to have stronger clinical skills. They're going to start to develop their own style as they move towards the end of these processes. And they become more and more aware of their own limitations and more capable of independent practice. These are later stage associates that you really want in group supervision with some of your newer associates, because they can help calm some of the worries and show your newer associates that there's light at the end of the tunnel. So we've looked at some of the basics, just kind of a review. Now let's consider moving into telesupervision specifically. You know, as I've mentioned, most of us are pretty comfortable with the practice of supervision, and most of us consider ourselves fairly expert at it if we've been doing supervision for a while. But most of us have not been trained in any supervision outside of in person in the same room. When we were trained in our master's programs and in our supervision certificate programs and in our supervision class for continuing education, it was all about meeting with your supervisees in your office for a group supervision And no one ever mentioned you might be doing this remotely. So our first thought is, okay, well, I'll just take what I'm doing now and I'll just do it on the computer. That'll be fine, right? And it's not that far off. I mean, a lot of what you already bring to the process works, but also we can enhance it and we can leverage some of the benefits and advantages that telesupervision brings to us. And I think I hear a lot of people talking about the disadvantages, which there are, but you know, let's also talk about some of the advantages. And really the fact that we don't have models for this yet, not surprising. You know, we were practicing as therapists, as a profession for decades before we had a need, or we had regulated and routine supervision. And we did that for decades before we had models and theories of supervision. So it's going to take a while before we have some good models and theories of telesupervision. We know that telesupervision lets us use technology for training, which can be helpful. We know it will let some clinicians access specialists when they want to get a certification or a specialty designation in a particular modality of therapy. Then they'll be able to do that without having to worry that there's no one who practices that particular therapy and geographically located near them. But for most of us, it's just about regular routine licensure supervision. So what can we do to do that well? So let's think about the benefits. I mean, it's a little bit cheaper to not have to it's a lot cheaper to not have to have an office. But also we're getting rid of the travel costs, which is both time and actual hard costs of gas, vehicle, etc. So it's more cost effective. We are making it easier for access for our remote supervisees and supervisors to be able to do their roles. We're allowing some consistency where a supervisor can work across the multiple sites of a single site. So a single site might have multiple places in which they operate, and the clinician might operate across different pieces of that site. And then that one supervisor can be part of all of that. There's a lot of flexibility when you're able to go from supervision from one site to another very quickly without having to physically do so. And, you know, it's a scalability issue always with technology. But is there a difference when we think about modality? I think most of us would say, I like being in person better. Most of us do. I like doing supervision in person. I like meeting with my supervisees, but it's not always practical. So when we look at what does the research say, comparing the modalities, if you take a look at the satisfaction surveys from at least this one study from 2002, there's a difference, that there was a slight advantage in satisfaction to the in-person model. And that's not surprising because people do love to be able to get together. And also, it's still very under-researched. So what we're seeing is we need to compare telesupervision with in-person supervision. We need to look more closely at the challenges of telesupervision and the benefits of supervision from a research perspective. We need to really analyze the components of effective telesupervision and what are the characteristics of the best type of supervisor for telesupervision. Right now, what we are seeing as suggested in the literature is that the relationship is key in terms of quality and efficacy of supervision, no matter how it's delivered. And I know you're not surprised by that. You can do all the models, you can do all the research, you can do all the fancy statistics you want, but when it comes down to it, in the profession that we have chosen, it all comes down to the relationship, doesn't it? If the relationship is solid, the outcome is solid. So focus on that. Yes, you're going to be using a camera. But if you can establish a good relationship with your supervisee, your supervision can be as good in person, on a video platform, regardless, because that's what you bring to this opportunity for your supervisees. Now, practically, we have to look at, there's some things that we do differently in distance supervision. We have to deal with technology. All of our work, whether it is the actual care of the client or the supervision session, needs to be in a protected system. So we have to understand, how is the technology set up? Where are its weak points? What is HIPAA compliant? What platform do I use? What do I need? And what happens when, not if, it fails me? What are my options? What are my clinicians' options when technology fails their client? We have to understand those regulations that each state has. You know, what is necessary in an informed consent in the state of California for telemental health purposes. And if I practice outside of the state, if I'm licensed in another state and have a privilege to practice because of that license, what does that consent have to look like? What do I need to know about risk assessment? What do I need to know about emergency services? How will I know where the client is? Now, that's all about the provision of telemental health, so I don't want to go too far afield there. But as the supervisor, I need to know that my clinician knows, and I need to verify that that is happening. And where is it all documented? Where are the notes? Where am I signing them? How are we editing notes? How is it staying protected? Most of us use an EHR already, and so that's probably where it all happens. But if not, then what are we doing? And if the EHR is not accessible remotely, that could be a problem. It used to be that EHRs were really just in-house within the clinic. But if we're now providing remote services and remote supervision, the EHR must be accessible from without to also be able to access the logs for hours and progress notes and treatment plans, etc. So some things that will work for you to be an effective telesupervisor. You should be fairly comfortable with technology. If technology is not for you, then probably this isn't for you. And that's okay. There are still so many of my students that have no interest in doing telemental health. There's always going to be a place for the in-person session, the in-person supervisor. The in-person client is always looking for their place. But we need to know how to troubleshoot some basics, and we need to know when to say this session can't happen or this supervision can't happen. And so we're gonna have to schedule another time because the board is gonna require that we document our hour. We need really good communication skills, which we already have, but we need to leverage them remotely. And then we need to be able to bring our wealth of clinical knowledge and experience into our telesupervision into such a way that we can guide our clinicians to help them become better telemental health therapists. And that's new for us, for most of us. Again, back to that in-person versus telesupervision. You know, when you're in person, you have so much greater vision of nonverbals. They're just more difficult to see from a camera, but they are able, and you can see that. I've heard therapists talk about with client care being worried about who else is in the room. I haven't heard supervisors talking about that, but I think that would be a consideration. Where is supervision being held and how secure is it? So the supervisor and supervisee may have to work a little harder on your working alliance. And how are you connecting? What's your communication style? How are you establishing that relationship that research study shared is the essential unit for a successful supervisory relationship? Cover with technology, and the medium is never going to be as important as you are. So for those of you who are thinking, oh my goodness, technology is going to take over the world, it's not going to take over you. We're not losing our jobs to technology because it will never, ever replace the human element. So now what? How do we leverage? The next thing is, how do we get our supervision better because we know how to use technology beyond basic video to make supervision at a distance even better. So let's think about what it's like for you and your brain when you see a client. You're thinking about your client, you're thinking about what their story is, you're thinking about who they are, where they live, who they live with, what's going on with them, when you last saw them, what their diagnosis is, maybe they're on medication, you know, all the things. And right at the end of the session, you kind of still remember all that, right? And then you see a whole day of clients, and you're like, okay, yeah, I still remember that one, but now we've added all these others, and okay, that was a lot. That was a lot, okay. Trying to keep up, I'm trying to keep up. But oh yeah, I also had a couple of supervision hours. So now we've added all these other clients that I have this vicarious responsibility and liability towards, because now I've got all my clients in my head and all my supervisees clients in my head. And here's where I think telesupervision, distance supervision is headed. How do we leverage technology? Because this is more than any of us can retain in our brains. Or I'll speak for myself. This is more than I can retain well in my brain. And you may be better at this than I am, but I don't think I keep all the details. So where we are with telesupervision is an opportunity to bring technology to enhance us beyond video. As it stands right now, virtually every platform that we use for clinical work at a distance or supervision has the ability to generate a transcript. So we can have a session, and at the end of a session, probably have a transcript. Even basic Zoom has a transcript. Now, I hope nobody's using basic Zoom for client sessions, but you know, HIPAA compliant Zoom or a HIPAA compliant DocsyMe, or there's a lot of platforms that are made for clinical care that have transcription options, and platforms that have more than transcription options. So I'm just going to show you some examples of some ways that we might help our clinicians as a supervisor, and we might use the distance technology to be better supervisors for these clinicians. So if I have a platform that's providing a transcription, that's a lot of data. If we think of words as data, then there's no reason that we can't get a qualitative analysis of this data. After every session as a clinician, I have an idea of what the session was about, and I could report that back. So my supervisees come to supervision, they tell me what their sessions were about. But I also in my clinic have a platform that takes this transcription and analyzes the data for me as a supervisor and for them as a clinician. And this is not the only platform around. There's a lot of platforms. But the platform that we use takes that content, provides the video. We hold the videos because it's a university training clinic, so we want the videos for a little while. Takes the transcript and runs it through a qualitative analysis and provides us with a number of data points that are helpful to me in supervision. So when I open up a session for a clinician and I want to spot check or watch how a clinician's doing before supervision, the first thing that I'm going to look at is right down here. I'm going to look at something called clinician talk time. And why am I going to do that? Well, I don't know about y'all, but when I was in my master's program and then later as a supervisor, it was just always understood that you didn't want to overtalk the client, but you also didn't want to undertalk the client. And as a supervisor, I try to share with my associates that I want them to have a meaningful back and forth with their clients, and that you don't want to have long periods of you talk nor long periods of them talk. So think back to your own master's program. Now, if you are, again, back from my generation, we actually had to type out these transcripts. You younger people have not had to deal with that. And part of the typing was to help you see how long you, the clinician, talked, or how long you allowed the client to talk. So this metric gives me as the supervisor an immediate window into whether any of that was happening. And here we see a clinician talk time of 45%. Well, I happen to know there's published research that correlates the amount of clinician talk time to a decrease in anxiety and depression over time. And the rate of talk time is 40 to 60%. Not surprising, right? I always just thought half and half, and that's about it. But what I'm going to look for here, and then I can go over here to these dark blue and light blue bubbles, because the bubbles indicate how long someone's talking. So here we have a fairly dark blue bubble, and this is a longish time. I want to know, what did my clinicians say there? As a supervisor, I'm curious. What would you have to say that was so long right there? I want to know. And if the client is talking for a very long time, and I've seen some bubbles, y'all, that are long, why is my clinician not interjecting or being a part of the dialogue at that point? So that's the first thing I'm going to look at. But I'm also going to look at keywords where it gives them to me for both the client and the clinician, which is just taking all the words and basically making a word cloud. I then look at techniques that were used. So this particular session, this platform extracted the fact, or it counted 19 reflective statements that the clinician made, 12 open-ended questions, 17 closed-ended questions. That may or may not be helpful to me as the supervisor, but it's not, it's somewhat helpful. It's interesting data. I mentioned the keywords, so I can see the words that the client used versus the clinician used versus the words that the client used. That might be helpful to me. And then techniques that were used in the session. If I'm looking for some particular technique, if I have suggested something, I can look for it there as well. And then finally, what that analysis of a transcript is going to give me are the themes that came up in the session. So I can pretty quickly see, we were talking about depression, anxiety, and relationships. Relationships seem to have the most discussion, but there's also a little bit of PTSD. So something came up in this session about a fire, and how did that impact the rest of the session? This was a new story your client told. How did that impact the rest of the session? It gives me some talking points with my supervisee. Even though this is a platform that we purchased and used, this is the direction that I think all platforms are going to have in telehealth, which is going to give you some rich data in telesupervision. Right now, you could take a transcript from any session that any telemental health platform would provide. HIPAA compliant Zoom provides a transcript all the time. And you can run it through a word cloud generator and get these types of themes that I'm showing you right here, and have something to bring to a supervisee and say, what does this look like what your session was about? Tell me about any parallels and consistencies. What do you think? Because again, what AI says the session was about is not always what the session was about. But it's a starting point, a conversation point, and a way to use leverage, a way to use technology to enhance your supervision. We've also used these data points to better understand maybe why things weren't working in therapy, where we saw maybe clinicians that were asking too many questions and not doing enough reflective listening. And being able to address that in supervision changed the course of therapy and the clinical outcomes. So how can we use technology if we're already using it in supervision to enhance our supervision? And then how do we use technology to help our clinicians? Where I also think we're headed is using technology to make our clinicians' lives a little bit easier, which will make their services better. One of our greatest difficulties in the field of mental health therapy and being a professional therapist is the burnout that is associated not with seeing our clients. That's the part we love, but associated with all of the paperwork, right? That's the thing I hear clinicians most concerned about. So part of what technology is helping us to do is take these telemental health transcripts and begin to develop ideas for a progress note. This is another platform. This is not one that I personally have used, but it's a platform that just takes the transcript of an audio recording and gives you some ideas for a progress note. And what we're seeing with this is that clinicians are turning progress notes around so much faster. They don't have that weight hanging on them. It is improving their stress levels and allows them to be more present with clients because they're not worried about what's hanging over them when they get out with the client. It also allows you to do more of your work in supervision around their clinical work and not reminding them of all the progress notes they're behind on. So as you think about becoming, and then not becoming, because you're already there, enhancing yourself as a distance supervisor, as a telemental health supervisor, it goes beyond hopping on a video call and providing supervision. And even that is wonderful. And yet, what else can you bring to the table? Your relationship is number one. Your skills, absolutely. You have other things you can bring to the table that will help your clinicians and help you as well. So let me leave you with these last takeaways. Your telesupervision is better when you are more intentional. You being your true self, who you are already, authentic and transparent, that is even more critical when we have this barrier of a video between us. Work with your supervisees to plan for when, not if, technology fails you. Stay on top of the ethical issues that are going to change more rapidly than this training could ever stay on top of. Same with technology. It is changing so fast. Our supervisory practice will have to change with it. So have fun with it. Know that what you're doing probably already meets the level of competency, but let's go beyond that to being really great at this and really influencing the models to come for what makes an effective telemental health supervisor. I appreciate your time, and please reach out if there's any more that I could share with you about anything from this webinar or anything related to this topic.